It's a real pleasure to introduce Dr. Chaichana, who did his training at Johns Hopkins and was on staff there for a while with Dr. Quinones. He's an associate professor, and we are co-chairing the brain tumor division, and now he is also in charge of our skull-based and minimally invasive neurosurgical division. He's brought a great deal of energy to the practice and has just kind of hit the ground running strong. And speaking of that, he doesn't like a lot of people to know he's also an ultra marathoner and has done, I don't know how many of these 50-mile runs. So speaking of hitting the ground running, here's Kai.
It's a wake-brain mapping for preservation of complex neurological functions. So historically, especially when I train, the eloquent brain regions, they're pretty much limited. You have Broca's area, you have Wernicke's area, you have motor cortex, you have the arcuate which connects Broca's and Wernicke's area, and you have the cortical spinal tract. So everywhere else, everyone thought it was okay to enter those areas, okay to resect those areas without any deficits, because when you do a bedside exam, they can hold up their hands, they're oriented ×3, there's no drift. But in evolution, there's a lot of other tracts that it's very hard to assess them at the bedside, but they're very important for quality of life. And these are things like the ventral premotor area, SLF, ILF, IFOF, frontal ascending tract, and the visual tracts. I'll talk more about those tracts later. And this goes back to a saying from Professor Yazergill from the 1960s, where all brain areas are eloquent. We don't really know what all the brain areas do, but even if you have a right frontal lesion and you do a resection, sometimes these patients don't wake up normal. You do an aneurysm surgery and you do a gyrus rectus resection, 20–30% of those patients aren't normal after that surgery. So why does it matter? It's because the neurological exam that we do at the bedside is not sensitive for detecting a lot of deficits. So when we do the bedside exam, all you can really assess is orientation and just gross motor skills. However, there are a lot more than that. Oncofunctional balance is critical. This is a term that really comes out of Hugh Defoe from France, and what it is oncofunctional balance is that you have to maintain a balance between extensive resection while maintaining their function. And an important part of function is preserving their quality of life, because a lot of these patients, especially for benign tumors such as low-grade gliomas, these patients are surviving for several years, so you want them to make sure that they can maintain their quality of life and return back to work. And here are some of the cases that I've done over the year. One is a professor, one is a professional go-kart driver, and one is an archer. So these are different functions that you can't really assess at the bedside when you do these tumor resections. So the general approaches to intrinsic brain tumors is that there's an oncofunctional goal that you want to balance between extensive resection and avoidance of neurological deficits. And the key to doing this is to identify where these tracts are and avoid these tracts and try to aim to preserve whatever function is most valuable for these patients. So how do you identify these functional brain regions? There are several different ways. Functional MRI is one. Diffusion tractography imaging is a good way for looking at white matter tracts. PET scans